grand rounds here for August. Going to be getting into a discussion of a particular case that involved some complications around induction onto buprenorphine product, Suboxone. Again, my name is Randy Brown. For those who don't know me, see a few names I haven't seen before. And I'm the director of the Center for Addictive Disorders at UW Hospital and director for our addiction medicine fellowships. Given that we're talking a bit about buprenorphine, many or most of you likely know the preparations that include buprenorphine are known to be effective and as part of the management plan for opioid use disorders or opioid addiction. And so we do a lot of work in our area around trying to build that workforce and support it. And so by way of a couple of introductory shameless plugs, I want to make sure that people know about some of those resources. So every month, the third Friday of the month, 12:15 to 1:15, we have a teleeducational session that is also on WebEx. So it'll look a lot like this, where we bring together all kinds of folks with different areas of expertise related to substance use issues and bring in primary care and other providers from around the state to talk about issues related to substance use and come to sort of some consensus around direction for plans and advice for providers that are new to care for opioid use disorders, yes, but also for other substance use issues that are commonly seen in general medical settings, such as alcohol and more stimulants such as methamphetamine. So if you're able to participate, again, that's on the third Friday of each month, starting at 12:15. And if you go to the Department of Family Medicine's website that you see at the top of this slide here, fammed.wisc.edu, and just search for ECHO, that'll be one of the first hits that you'll get, and you'll get more information about how to sign up for it and what that format looks like. We also run a call-in service. So for those of you taking care of patients, if you're seeing someone in your office or hospital where substance-related issue is complicating their care and you'd like to access addictions expertise, you can call the UW Access Center. You can see the numbers there, and an expert in addiction medicine or addiction psychiatry will be paged and connected to you so that you can talk about what's going on and what a reasonable plan going forward for that medical management might be. For those of you who are learners or maybe mid-career and thinking about this area, we also do run an ACGME accredited fellowship program that leads to board certification in addiction medicine, and information on that is also available on our website. Another thing I'd let you know about, again, we're pretty active in trying to build the workforce around substance-related issues generally, but also particular to opioid use disorders, and we do run some trainings that are related. We just had one at the end of July, and we'll be running another one in October, and hopefully leadership at UW Health will be getting that save the day out soon. And so on the first day of this data waiver training and boot camp, we'll be conducting an interactive training session of 4 hours to supplement online content that will count toward getting that data waiver, authorizing you to prescribe buprenorphine products such as Suboxone in your practice. So as this is 4-hour interactive for physicians, there's an additional 4 hours of required online content. And for APPs, there's an additional 20 hours of online content that includes a lot of that opioid use disorder related material, but also includes a lot of good material around the management of other substance use disorders that are frequently comorbid. And so that's on the afternoon of our first day. And our second day, we're going to be taking a deeper dive into just how you get this going in your practice, because we know that a lot of individuals that take the training leave it feeling like that wasn't quite enough and they need a little bit more by way of information and support. So again, I let you know about some educational resources we have available to serve part of that purpose. But we're also going to take a deep dive in the context of this boot camp to bring in a number of providers that are experienced in delivering this in primary care settings and engage in some interactive activities to just get people more knowledge and getting to feel more comfortable about initiating this practice through this boot camp. If you're interested in more information, our primary contact is our coordinator on this, Kathleen Marr, and you can see her email there. And this session is being recorded and you can access that later as well, and we can get that information out to you. And I'm just kidding, we will not make you do burpees at our boot camp. So for our case, this was someone I was seeing with a fellow in one of our clinics, and his initial visit, this was a 45-year-old male who had a fairly extensive history of regular injected heroin use, multiple prior treatment contacts, and had periods of abstinence, primarily related to periods of confinement. And when he came to us, he'd been released from 18 months in the prison system. During his time there, he was actually able to access Suboxone at this fairly low dose that he took pretty well throughout his period of confinement. But then when he was released, was unable to access it immediately. And so he relapsed to regular heroin use, sort of alternating that with morphine, depending on what he was able to access. And while we'd made an attempt to see him in person, since he was someone we weren't super familiar with, that didn't work out due to some challenges with his transportation. We had an initial visit over telephone, and he reported that his last use of heroin was 2 to 3 hours prior. He didn't endorse any other active substance use, did have a remote history of stimulant use and probably use disorder. And his alcohol use was low risk with an audit C of 0. I already made mention of fairly numerous treatment contacts in the past for his use disorder. So I'm going to move into a spot where I'd like to hear some thoughts or questions from folks. Given sort of the audience, what I'm hoping we might do is if you can type things into chat, and you can send those to me or to everyone, whatever you're comfortable with. And I'll pause there and see what further questions people have about him before I present more information. So for example, a question I might throw out is, given that history, would you be thinking about starting Suboxone now or no? Any history of overdose was asked. And not that we got on that day that was recent, and not since his release from prison this time. And another person asked about chart notes, and unfortunately, we're not able to share protected health information in this forum since we're recording it and it'll be publicly available. And I see yeses to starting. Was he still using Suboxone while using heroin? And no, not since his prison release. He was not. He was just using the heroin. Okay. So far as just a little bit of other information, he was relatively healthy. He hadn't had much contact with medical care other than while in prison, and that was primarily mental health, where he received a prescription for stimulant for an adult ADD diagnosis there. We did receive records from his confinement, and there was remote documentation of the possibility of a bipolar spectrum disorder, but more recent notes were starting to call that into question. And by way of exploring risk behaviors, he did utilize Vyvanse, a syringe service program, denied any sharing of needles or works, but did endorse some reuse of those materials when he was unable to access that. He did have naloxone in the home. He lived with his parents, which I think I get to actually here in a little bit, who have been supportive, and they've been educated around overdose recognition and intervention, and actually had the Opie Rescue app. For those not familiar, there is an app for that that guides people through recognition and the steps in intervening for an opioid use disorder. The immunization registry indicated that he had completed hepatitis A and Hep B series. We were unable to locate hepatitis C or HIV testing recently. A couple more questions. Was he stable on Suboxone before? He did not make much of a run at it. He actually followed with me 12 years ago for a couple 3 visits, and then dropped off again due to legal circumstances. No really significant family history. Again, living with his parents. Some barrier to getting into town by way of challenges with transportation and living outside of Madison. Recent sexual risk, fairly low. Not currently employed. Anticipating around 2 years of supervision and participating in weekly DOC groups targeting substance-related issues as a required part of that. And no significant reported history of adverse childhood experiences or abuse and neglect in the home. So given that, we already got some answers indicating that going ahead with Suboxone could potentially be reasonable. And so we did. Again, I made mention of the fact that if you're not muted, can you make sure to mute? I'm getting a bit of feedback. Thanks. So since his use was fairly recent, we were not able to induce right there in the office. I'm still getting a lot of feedback. I don't know if others are. If you aren't muted, can you make sure that you're muted? Thank you. All right. And so a lot of practices, though not all, are moving toward home induction being a part of what they offer. It has been demonstrated as being feasible and safe in randomized control trials. It can, depending on the setting, can overcome some barriers for patients like, transportation or feeling uncomfortable being in a waiting room and active opioid withdrawal that's needed prior to Suboxone initiation. And there's some self-administered scales that you can use in this context, so that in addition to being a certain amount of time out, at least 12 hours from a short-acting opioid, 24 or even 48 hours out from longer-acting opioids, that they're in moderate withdrawal prior to initiating Suboxone or taking that initial dose. And you can see this is a figure from Joshua Lee's initial RCT in this study. That's sort of an excerpt from their patient handout. So if you check on this article again, Joshua Lee around home induction, there's an appendix separate from the article where you can get some of that patient education around home induction if this is something that you'd be integrating into your practice that can be helpful. So moving forward with Mr. J's home induction, 14 hours after his last use, he was starting to experience anxiety, craving, nausea, and hot and cold flushes. He took an initial 2 milligram dose. Oftentimes, protocols will pretty commonly recommend, as you saw in the last slide, starting with 4. But he opted to start with a somewhat lower dose at night. Someone says they're not seeing slides. Not seeing the slides? Okay, sorry, just a sec here. Okay, now I've lost the view of everyone. Kelly, can you maybe unmute and let me know if you're seeing it now?
Yes, I see them.
Okay, great. Thanks for cluing me in. So, Kelly, how far back were the slides off?
I have
If
to
I
admit
should go
I was
back.
not seeing slides. And until you started referencing the slides, I wasn't.
Okay,
I was just listening more to the case.
I got you. So this is where, I'd gone through some of the material with the case. So hopefully that was fairly clear. Heather, if you're there, the view that I'm on now that's getting folks access to the slides is probably going to block chat for me.
Okay.
So the next time I pause, maybe if you can track that.
Okay.
Well, actually, no, I'm getting some pop-ups, but I'll keep you posted.
Okay.
Thanks, Heather.
Sure.
And this is the figure that I was making mention of by way of the appendix and some information around home induction. That's worth review. Dr. Salisbury Afshar, welcome. Dr. Salisbury Afshar, she's new to us here, came on as addiction medicine faculty at the beginning of this month. So yeah, there are some materials out there that can be somewhat less complex. And, and actually going through these self-administered formal scoring questionnaires can be confusing for some. And so something that I'll often do rather than having formal scores done by the patient is more talk to the patient about their customary withdrawal history, which they'll be able to recount accurately. And if you can get a sense of sort of the timing with which they'll be experiencing symptoms more common with moderate withdrawal, so things that go beyond the early anxiety, initial craving, maybe even hot cold flushes, and they're experiencing more uncomfortable physical symptoms in addition to that, like GI or bone muscle aches, watery eyes, runny nose. And it's that reasonable time out from last use, you can feel fairly certain, with some potential exceptions that I'll be getting to, around initiating a dose. So then getting back to the case here, he'd taken an initial fairly low dose around bedtime. That went very well, and he slept through the night. So with that initial dose, it appeared that he was far enough out from last heroin use and in enough withdrawal that was well tolerated, because as a lot of you likely know, if they've used opioid very recently, they're not in withdrawal. Buprenorphine can precipitate withdrawal or cause a very severe withdrawal. And he seemed to tolerate that quite well. He woke up the following morning and took another 2 milligram dose, was experiencing some anxiety, took that and didn't feel much improved, and then came to clinic for us to follow up with him and continue dosing. We gave another 4 milligram dose in clinic, and still some anxiety, not experiencing particular relief. And then after a second dose, he actually began experiencing symptoms of more severe withdrawal that he identified, including more severe chills, sweats, abdominal cramps, and moderate to severe body aches. So what sorts of things are you thinking might be happening, and what sorts of options would you talk to folks about? And again, at this point in the middle of the presentation, we'll ask you to do chat. And then at the end, I've left time for discussion where we'll work on sort of opening the mics and having people unmute and doing more detailed discussion. Allison asked, has he been using methadone? And no, he did not endorse using methadone, just heroin. by his report for 6 weeks since release from prison. And Dr. Salisbury Ashar tells us, wonder if fentanyl might be contributing. His last heroin use at this point is about is more than 24 hours out. And how did he take the Suboxone? Good question. It was taken sublingually. Yes, that is a very good question. You know, patients, if they don't receive that counseling, you know, in the population of individuals with opioid use disorder, Suboxone use is how it's done is known by many, but it is important to emphasize that this is sublingual, needs to be left to dissolve in the mouth, and if it's swallowed, that'll render the buprenorphine ineffectual. Any benzo use or other drug use that might be complicating the picture. Not that he reported. And I'll say, you know, given the assay that we have available in our system, you know, as folks are coming in to initiate Suboxone, it's tricky for us to have a result at point of care, unfortunately, which would be really helpful. So at this point, we were thinking that he was in precipitated opioid withdrawal. And so how does that get managed? Should it be managed differently than, you know, opioid withdrawal otherwise? And hasn't been really studied in scientifically rigorously designed studies with standard dosing or comparison groups. So there's really pretty little consensus about the plan that should be offered to all. And there are some options. So you can do an agonist based where the individual may monitor their symptoms and you can continue to escalate the dose of the Suboxone by 1 or 2 milligrams every 1 to 2 hours until there is relief. May need some adjunctive medications to help throughout the day when moving toward that. Non-agonist based, where essentially you're saying this trial of initiation in this way has failed, so let's take a step back, stop dosing for now, provide comfort medications like clonidine, lofexidine, and adjunctive medications needed to control symptoms, and then reattempt again in 4 hours. And something I'll be talking about in a bit more detail later is there gotten to be regimens studied around micro dosing or starting with smaller dosing to move more gradually toward the therapeutic dose of Suboxone that they might land on. And if individuals are experiencing particularly severe precipitated opioid withdrawal that really I've seen more in the literature and in clinic, if it's attributable to Vivitrol than Suboxone, then may need to consider referral to more urgent care, ED, or consider hospital admission. So I've been alluding to some of these self-administered assessments around opioid withdrawal severity. So just wanted to show you what I'm talking about a little bit here. This is a subjective opioid withdrawal scale. As you can see, there are 16 items that the person scores on a 0 to 4 Likert scale in terms of severity, with 4 perhaps obviously being the highest, and with scores total of 17 to 32 indicating moderate withdrawal, and scores greater than that indicating more severe withdrawal. There's a shorter, called the short opioid withdrawal scale, GOSSOP, G-O-S-S-O-P, that involves 10 items, so not horribly significantly shorter, but some. And the asterisk items here are the ones that are included in that, along with a couple others that are added, such as heart pounding, muscular tension, and insomnia. And on that scale, with those 10 items, 21 has been graded as severe, with there being less validation of that instrument around sort of the moderate withdrawal severity and in the context of Suboxone initiation protocols. So this is the agonist-based opioid withdrawal management in just a little more detail here, where the patient, you can use one of those self-administered scales or guidance that's more symptom-based, based on conversation with the patient and their typical withdrawal course. And typical protocols have had folks assess themselves around 4 times a day. And with that subjective opioid withdrawal scale, self-administering 2 milligrams sublingually, moderate withdrawal, 4 milligrams for more severe withdrawal with a max of 16 milligrams in 24 hours. And in this context and in these protocols, they've suggested that insomnia can still be a particular problem and can consider agents for that. And there's some examples of what they've offered in these trials there. But the big thing here is really to anticipate fairly close follow-up, make sure that the withdrawal is getting relieved and under control, because we know that more complicated initiations are associated with lower levels of engagement and retention in treatment. So to the extent we can, we really want to get these symptoms under control as efficiently, but also as safely as we can. I made mention of the microdosing approach that started to be getting more attention lately. And part of the reason that it has been, and question or comment came up related to this earlier, with the presence of fentanyl in the heroin supply, that may make this a consideration. And I'll be talking a little bit more about the ins and outs of that and why fentanyl makes this a potential consideration. So that the Bernese method has primarily been studied in either ongoing opioid use, including heroin or methadone, or in the early stages of withdrawal from fentanyl, which I'll be talking about later as having potentially more extended activity at the mu opioid receptor with regular daily use. And starts, as the name might imply, microdosing with quite low doses initially. And in the protocols that have been looked at, which are basically in case series, these initial doses and how they build can vary quite widely, with initial doses ranging from 1/4 milligram to 1 milligram. So with the lowest dose formulation being available commercially is 2 milligrams, then you're going to be asking patients to cut these into quarters or eighths, and move the dose forward as you see there. And the idea is basically, in our sort of our go-to pharmacologist, I know wasn't able to make it today, Paul Hudson, who'd given us some feedback on this, and I didn't see the list to recognize if there were other pharmacology experts on here, but we'll look forward to your input with discussion if you are there. But the idea basically is that in gradually introducing this partial opioid agonist with very high mu opioid receptor affinity, this regimen is allowing for more gradual occupation of the mu opioid receptor by that partial agonist, and reducing the likelihood of precipitated withdrawal in that way. And then many, if not most, are likely familiar with more typical approaches to opioid withdrawal management, with clonidine, an alpha agonist, for example, and the other potential adjuncts. Lofexidine is a more recently FDA approved alpha agonist that has much less risk by way of orthostatic effects. And so unlike clonidine, it can pretty well be started right off at what's typically a therapeutic dose for the symptoms of opioid withdrawal that it's going to ameliorate, which are primarily the autonomic issues around anxiety, hot, cold flushes may be relieved to some degree, tremulousness may be relieved to some degree. And then, so that leaves a fair laundry list of other symptoms to potentially address, including more severe anxiety, nausea, abdominal cramping, bone and muscle aches, lacrimation, rhinorrhea, and for agents to be targeting on an as-needed basis. And that can be a pretty confusing laundry list. And so this is another place where I'll, as a matter of routine, talk to patients about their withdrawal course and what they experience and what they expect to be getting severe for them. Start right off with one of the alpha agonists, and then add just a selection of some of these things based on what they anticipate by way of the aspects of withdrawal that are more challenging for them. So in talking with Mr. J about these options, he elected to discontinue the initiation that day in clinic and to use comfort medications and reattempt initiation the following day. And so he took a 4 milligram dose at 8 a.m. That went very well. Another 4 milligram dose at 11 a.m., which went well, and was reporting no withdrawal symptoms at noon that day. However, 2 days later, as he was looking to maybe be stabilizing at around 12 milligrams total dose daily, he began experiencing withdrawal symptoms again, with primarily cold sweats, nausea, aches, and tremor. But then the following day felt well. He then lost contact with the clinic due to a death in the family and loss of his phone service, in addition to the transportation difficulties. And we didn't see him until 10 days after that last report I put up on the last slide. He was having some ongoing concerns of subjective withdrawal at 4 milligrams 3 times a day. So he stopped taking it and resumed lower level heroin use for a week. Then he abstained for 3 days, began experiencing withdrawal symptoms that he identified as being moderate to severe. He reinitiated with 8 milligrams, continued with 8 milligrams, and had no difficulty doing so. So a number of you I saw in the chat threw out the spoiler. Maybe fentanyl is what's going on here. And it did turn out that his urine drug testing was positive for fentanyl. And it's something to have on radar. There's high penetration of fentanyl and analogs into the illicit opioid supply, particularly in the Great Lakes and Northeast areas. Forensic reports of fentanyl have gone up 50,000 times since year 2013. So this is something that's really taking off at a pretty alarming rate in pretty recent years. And the issue with fentanyl, you know, in inpatient settings and with the bolus dosing often done for conscious sedation, things like that, we're accustomed to thinking of it as something that's fairly short acting. Sorry, I'm getting some feedback again. I think someone may have unmuted. If you could check on that, appreciate it.
Yeah.
So fentanyl, though, under those circumstances, is fairly short acting. It is lipophilic and highly protein bound. And so with regular daily use, those properties may confer some risk for it to accumulate and for it to be present on the mu opioid receptor for longer than some of the other opioids that are commonly misused. There's also been identified pretty high inter-individual variance in metabolism. And this then all confers potentially increased risk for precipitated withdrawal when fentanyl is in someone's supply and they're using it regularly. I'm still getting a bit of feedback. If folks can double check that they're muted, that'd be great. Really appreciate it.
Yeah.
And in one study, there was a qualitative survey, 63 individuals, and a large number of them did indicate that they experienced precipitated withdrawal, even 48 hours from a last dose. So, you know, all things considered, we're in the fairly early goings with considerations about how to account for fentanyl in opioid supply in clinical practice. The first case series of microdosing protocols specifically looking to alleviate this in fentanyl were only published 4 years ago, with more coming out with fair frequency over the last 1 to 2 years. And the tension here is, if we're prolonging stabilization, we may also be prolonging the duration of opioid withdrawal symptoms, and that is also associated with a lower likelihood of ongoing engagement and treatment. So what do we do? Some things I just throw out to consider. It'd be nice if we had reliable point of care testing for fentanyl, so we had those data more real time. But given the penetration of fentanyl in our supply in the Midwest, Great Lakes in particular, to what extent does that really change practice? Might consider lower dose initiation, and in a number of these protocols, specifically looking at samples where fentanyl was detected, that initial doses ranged even up to 2 milligrams. In that initial microdosing table, I demonstrated that initial only went up to 1, but that has gone as high as 2 as an initial dose. So I know it's fairly common practice to start right off at 4, but maybe sort of starting at lower might assist in preventing this too. Again, I made mention of microdosing protocols where the opioid use is ongoing, with really low doses of buprenorphine being given and gradually escalated over 6 to 8 days. And then the opioid use, aside from the buprenorphine, is discontinued on those latter days. And in these case series, again, not scientifically rigorous study yet, they've had some pretty good results. Another thing we'll sometimes do in clinic is administer a challenge with nasal naloxone to ensure that doesn't precipitate withdrawal and anticipate that we may be able to move forward with a more typical initiation. So, and that's what I had today. So I know I missed quite a bit by way of the chat. So I haven't done my, so maybe folks we can try just unmuting now and see what questions or comments folks have.
Randy, one thing I shared, I'm working on a project in Delaware, and for people who aren't familiar, the Northeast is almost entirely fentanyl now, particularly the further Northeast. And so it's been kind of moving west. And so there were some concerns in a project I'm helping with in Delaware about home initiation and how do you manage home initiation given the predominance of fentanyl. So I did an interview of maybe 20 colleagues in the far Northeast. And I think the most interesting response I got back, they were all pretty similar, which was consistent with what Randy shared, but was from a colleague in Western Mass who said that so she works in a jail in an outpatient setting. They've had fentanyl since 2016, but she said that in the last 4 to 6 months, there's been a tremendous shift and there's a change in what they're seeing. And she thinks that for some reason, the fentanyl seems to be more lipophilic because she actually watches people primarily in monitored settings like incarceration and detox. And so she said they've had to change their protocols. So they're now, because they just assume everyone's only fentanyl, and they're microdosing 1 to 2 milligrams every half hour in the monitored settings. And that they used to have people wait 20 hours if they had a fentanyl positive urine drug screen. Now they're having them wait 30. And so she's been doing this for 4 years, and there's been this really significant shift. And in Chicago, which is where I'm from, we're just starting to hear more about these issues. So I think there is some type of change in some of the drug supply, including coming to the Midwest. So I anticipate it's something we'll see more.
Yeah.
Great, and I saw Dr. Bhatnagar was on. Is this something at New Start you've come across, or had experience with withdrawal you think might have been attributable, or made any changes in your protocols or added other options for it? Or did she maybe have to go? It looks like she dropped off. We actually have another patient in the hospital now where we've been thinking a little bit about the microdosing issue. Is a man who'd been on 180 milligrams of methadone for 22 years, doing quite well with that. And he was admitted after a cardiopulmonary arrest, VFib, and QT prolongation, which, as many of you know, methadone can contribute to or cause. So his methadone was held. Other opioids are being used to control withdrawal. And we're thinking a little bit about potentially a microdosing approach to getting Suboxone going and coordinating that with his OTP as he leaves there. But we're still awaiting some follow-up with him. This was a person who was pretty connected with the OTP and felt like methadone was what really helped him. And so he needed a little time to think about it. He was kind of distraught about that. Oh, something in the chat there. And Kelly mentioned participating in a PCSS webinar discussing transdermal buprenorphine to facilitate microdosing. Effectively, the patch delivers true microdose over the first few days, and you can get sublingual dosing, just a more general approach. Interesting. I haven't seen that. Thanks, Kelly.
Okay, I wanted to ask about some of the legality around that, because Kelly, I looked at that webinar and it was being used for chronic pain. And I mean, technically, I don't think that legally you're allowed to use the transdermal patch for treatment of OUD. And I just didn't know if that was something others had done and sort of how you documented it. Because I don't think that you could do it for someone if the only diagnosis was OUD, is my understanding of the regulations.
Well, it could be used off-label, but if it's used off-label, the issue might be that payers will cover it. But
I think it's actually illegal because
I don't think so.
Okay. Yeah,
No.
maybe not. I thought the Harrison Act made it illegal unless it was covered under the.
No, actually, on that front, yep, on that front, you're right. Yep, I stand corrected. Well, give it a minute, see if folks have any other questions or comments. We are recording this session so we can get word out to the group about how to access it, or if your colleagues want to access it.
Randy, this is Kelly. I suggest someone microdose someone soon, and then we do a grand rounds to follow up the experience. Or maybe we do a couple and then follow up, because I think there's a lot of us reading and interested in this, but no one has yet to do it. And
Dive
so
in.
we'll learn a lot from the first few times.
You, Elizabeth, and I can draw straws.
Yeah.
I will just say I've done it, but not purposely. Like, we've had patients do it based on the formulations we give them, which has been fascinating. Yeah. And I think when you have really savvy patients who are really used to getting drugs on the street, they find all kinds of ways to do things. And so we've the first time I learned about microdosing was from a patient who had been taking street methadone and told me he knew it could work, and it was so new to me. And he came back 3 weeks later and was like, I already did it, here's my dose, will you prescribe? Because I was like, I need to read, I don't know. And then he no-showed, and then he came back like, okay, I'm good, I'm solid, let's start. So I think it's also depending on the history of the patient. Sometimes people already have a sense.
Yeah. All right.
Randy, Glenn typed in a question that I think is good.
Why, I didn't catch why fentanyl and bupe cause withdrawal together, what's happening at the level of the receptor. So let me see if this answers your question. I was hoping Paul might have been on to go into more of the nitty gritty pharmacokinetics with this. But he forwarded me some things and I think I can at least get at the crudities of it. And the issue with regular use of fentanyl and its lipophilic nature is that it can accumulate have a large volume of distribution, fairly gradual release into serum, as well as dissociation from receptor. And so that's the issue where there's still that presence of the full agonist on the opioid receptor, and longer periods of time out from last injection use of fentanyl than we would anticipate being a problem may still be a problem in terms of doing your typical induction with Suboxone at say 4 milligrams at 24 hours out from last use. Is that helpful, or did I just?
What I was wondering was if buprenorphine was displacing fentanyl from the mu receptor, why doesn't buprenorphine just bind and prevent the withdrawals? Because it sounds like they're both displacing each other, and then that's precipitating the withdrawal.
Right. So, and I'm not sure if I'm grasping what you're getting at, but the idea is with those much lower doses of buprenorphine, you're not displacing so much of that fentanyl that you're precipitating the withdrawal. And there's this more gradual build with the microdosing gradually escalating and bringing about that displacement that doesn't create the precipitated withdrawal. Does that make sense?
Kind of. I'm still struggling to understand why that is. Why, if both of the opioids are present, both could bind to the receptor. Why would there be withdrawals?
Oh, well, because the buprenorphine being a partial agonist doesn't turn those mu opioid receptors fully on. And so if a partial agonist, higher affinity, displaces a large proportion of that full opioid agonist, you put someone into relative opioid depletion and withdrawal.
Thank you. Yes, that makes more sense there.
Okay, gotcha. All right.
Quick question. We were inducing, and her use had been fairly recent, but she said she'd been using test strips on her heroin, and it was negative for fentanyl. How reliable is that? We were trying to use that for induction yesterday.
Yes. The Vibrant Syringe Service Program has been dispensing fentanyl test strips. And this is done in many other locations as well, given fentanyl in the supply, so that individuals can dissolve some amount of drug in water and test it for presence of fentanyl. So issues with it are, the science around that practice isn't perfect yet. Those strips have been validated for use in urine samples, so there may be some effect of pH. And also, even when optimally used, their sensitivity is just over 90%. And so every 10th test-ish is going to be falsely negative. Yeah, great question. Thanks for that.
I had a question. I was wondering, so if we're seeing with more fentanyl, what about like transition onto methadone versus going to bupe, and then like any thought around that, or?
Oh, having this patient do methadone rather than Suboxone?
Correct.
Well, great question. But, I don't know that presence of fentanyl in supply, to my mind, would be sort of primary reason to think methadone is being preferable to Suboxone, just given sort of, you know, that level of care and its accessibility and things along those lines. And I think there are other factors that would be more primary to me than the presence of fentanyl in deciding for buprenorphine as opposed to a methadone formulation. But
what about like on an inpatient detox, so like a methadone taper for withdrawal and then transition to Suboxone, give time for the fentanyl to work out?
Right, except it's also illegal to use methadone for purposes of detox outside of a federally and state licensed treatment facility as well. Unless it's done on 72 hours or less and it's dispensed and not prescribed.
Yeah, yeah. That's a pretty short course for methadone. And then you also have sort of another long-acting agent. And I mean, I think we probably have some to learn by way of whether that would confer advantage or, you know, induction after fentanyl versus after methadone. Good question.
Randy, there was another question about from Allison.
Oh.
Do you want me to read it to you?
Oh, yeah, I got mine. With the microdosing, getting patients started on very low dose, encouraging continued use to manage withdrawals. So honestly, I haven't done that yet, but that is a very specific framework for the microdosing that has been done, particularly in the case of methadone, where that microdosing protocol starts and it gets ramped up over 7 to 8 days. And then the methadone, and this has been in doses from 40 to 70 milligrams in the literature that I was able to locate by way of case series. And then at that time, the methadone is dropped, and then you anticipate that the buprenorphine dosing will need to be further titrated after that time. So yeah, that has been done in case series. I haven't done it yet myself.
Yeah, I would just add, in talking to people in the Northeast, which is not in case series and is not published, I think that is the balance that they're trying to reach, is like how quickly can you microdose to keep people comfortable and reduce use. And so people were trying to get up to 16 in the first couple of days for that exact reason, but the response has been variable from what I'm hearing. And so they were trying to offer more support meds. Generally, I practice in Baltimore, we don't give clonidine to anyone because it had such tremendous street value and it was involved in a lot of overdoses. So like we didn't use it a lot there. So at least the Baltimore colleagues weren't using clonidine because it just says in general, we don't. But trying to use other support meds and then making sure that people could get up to 16 pretty quickly so that it's not just this sort of continual, they keep using heroin, which is really fentanyl, which then is just like this vicious cycle.
Yeah, right. Nice. Oh. All right. Great. Well, really great discussion, everyone. Really appreciate everyone throwing in on that. And maybe we will have a follow-up. Oh,
Randy, there was one last question.
Yeah.
I don't know. It looks like somebody's looking for an answer.
Would that be easier than dealing with fentanyl? I'm not sure. You know, and microdose quickly if possible. And then we talked a little bit about microdosing to transition someone from methadone to Suboxone, and the regimens that I've seen in case series that's been started while they're still on methadone and gradually ramped up to fairly, moderate doses over 8 days. And then the methadone is stopped and the buprenorphine is up titrated thereafter. All right, sorry about that, Joe. All right. All right, well, thanks again, everyone. And we will see you again first Wednesday in September, we hope. Take care, be well.
Thank you.